Dr. Geeta for their wonderful presentation. Now I invite Dr. SANITHA Sathyan to present topic on surgical management of CVI.
Thank you, Dr. Geeta, for giving me an opportunity here. I'll be talking about surgical management in children with cerebral visual impairment. So, what makes it different in a child with CVI? So, we know that they have a primary ophthalmic pathology along with their own disability specific challenges, which makes it very difficult to manage these children sometimes. The first and foremost thing which I would like to talk about any child with CVI is when you have counsel for the surgery and the patient is first meeting the anesthetist, a thorough preoperative assessment is mandatory. You have to do a thorough systemic screening. You have to do a cardiac echo. That is sometimes all these children may have even syndromic cases will have some associated cardiac problems. Parents may not have realized that. They might tell you that she's all asymptomatic, no problems, but that has to be thoroughly screened. Always take a cardiac echo to rule out any anomalies. Get a fitness from the pediatrician, cardiologist, neurologist if necessary. And most of the children, they come with their MRIs and all those features. And that has also to be taken into account. Many have seizures because of this HIE induced problems. This has to be properly attended to. Their renal status, sometimes an abdominal ultrasound, all these may be required when you look into children with this cerebral visual impairment when they are going to surgical procedure. During anesthesia, always anticipate a difficult airway intubation. So you should be prepared, whether you do with a ET tube or IGL doesn't matter, but you should anticipate any difficulties and be prepared for that. Like this child with a low receding chin, and this is a case of difficult airway intubation. And also some children have a large tongue because of the syndrome associated or some hypothyroidism also. So the anesthetic should be looking for all these things prior. And associated seizure disorder has to be managed because most of these children, they will be on drugs. And then when you're they usually they have sometimes if you have a controlled seizure for 6 months or so, you might very well go on with the surgery safely. Sometimes you might need a loading dose also prior to the surgical procedure. And we can always expect a delayed recovery from anesthesia. So don't panic, they will recover, but delayed recoveries are also common. Post-op care. Post-op care is very important in these children. Surgery done, and it's very difficult to manage any child after surgery. When you have a special child, pain management has to be adequate. Like for a strabismus surgery and all, I usually give analgesics for 2 or 3 days, after which the patient should be okay. But CVI child, you have to attend to their pain, maybe analgesics for some more time. Parental counseling is very important, and always they have a aspiration risk. So they can develop pneumonia. So you should be able to prevent such problems post surgery, and they have more risk of infections also. And one thing I would like to tell you is that most children, see, after bilateral strabismus surgery, some people have we might patch both the eyes for some time. So for a CVI child, it's very alarming. Like if you're closing both eyes after surgery, the child is not getting any visual input. So that might create a lot of havoc in the recovery room. So I usually don't patch them. You have to prevent eye rubbing post-operate. All that is okay, but at least use shields so that they will be very sure of their environment in which they are when they recover. And different conditions. This congenital nasolacrimal duct obstruction is very common in children with syndromes, especially Down syndrome and other associations. So you are giving a short GA, but you have to take all the precautions for a proper GA, because this is a little risky procedure, and then it's not as simple as it seems. And punctal stenosis is common in children, so you have to have the dilator ready, different sizes, and the risk of repeat procedures has to be explained to the parents. And congenital cataract, again, this is a very important thing, because you need to, usually we calculate IOL power for adults preoperatively. In children, especially with those with special needs, we may not be able to do it preoperatively. So IOL power calculations are done under GA in the OT. So you have to keep your staff and equipments ready for that. You will need to keep a inventory of IOLs. You usually follow the normal normograms. And primary posterior capsular excess with anterior vitrectomy is done in almost all the children, whether CVI or not. But I would like to say, in those children with CVI who are grown up, there also those who fall out of the preview of a PPC also, we generally do a PPC, because that is always safer to prevent a PCO formation and repeat procedures. We use self-absorbable sutures, because suture removal is going to be another GA. And this is a situation in which bilateral sequential cataract surgery can be contested. But again, I would, if the risk of GA is not that severe, I would always prefer to do one eye first. And strabismus is rather common in children with developmental delay, and esotropias and exotropias are seen. They can have any kind of squint, vertical squints, all those are very common in these children. Because of multiple factors, the results of a strabismus surgery are less predictable in children with developmental delay, because of the, I don't know the cause, probably because of tone of the muscles, accommodation problems, and all those makes our surgery a little less predictable, and normograms need to be optimized. So we have a small data on that, which says that patients with CVI had significant undercorrection than controls. So this has to be taken into account when you do your surgery for children with CVI. And all the oculoplasty procedures like entropions and ectropions are common. One problem with them is that eye rubbing is a very difficult thing to manage. So chances of recurrence has to be explained. Trauma and infections, this is another problem, because all these children with some have head banging and seizure disorder. So the post-op management becomes really difficult. You'll have to operate again and again with GA exposure, multiple surgeries. The post-op care is a nightmare, and also a great financial and economic burden to the family. All this said and done, children need post-op rehabilitation with refraction, spectacles, and their integration into a proper education system. So one thing before I conclude, I would like to say is that, see, most children with CVI or special kids, they do have a lot of exotropias and a lot of squints. And there is some amount of parental pressure on the ophthalmologist to do surgeries, because mother doesn't like a child with a big exotropia walking around. Child is not looking onto the face, eye contact is less. So they'll ask, doctor, can you correct with this with the surgery? You should do surgery, but always counsel them, because see, autism is not a disease, it's a visual perception disorder. Children with autism can have CVI, but you doing the surgery and correcting exotropia is not going to solve all their problems, but the expectations may be high. So this kind, I'm associated with National Institute of Physical Medicine and Rehabilitation, where I do the CVI clinic, and there a lot of people come around with this kind of questions. But as ophthalmologists, we should convey this clearly. Again, when you do a surgery in a child with exotropia, the advantage is that binocularity is much better if you do an early surgery. But again, that is a questionable thing in children with special needs. So all this said and done, each child is special. That's why they're called special children. So each requires different kind of approaches. Consider the parents, mothers, while doing surgery. So I'm concluding there is a higher prevalence of ocular problems, proper precautions, especially during the GA and post-op period, and consider the holistic profile of the patient and caregivers before attempting surgery. Thank you.